So imagine a sound inside your head that only you can hear, and it won't stop. It's there day and night, and it's worse when you lie down and try to go to sleep. The quieter the room is, the more terrible it is. It's driving you crazy. You get online, you start going down rabbit holes, finding all kinds of conflicting information about it. We're going to talk a little bit about tinnitus, because that's what it is. It's not scary. It's something that 14% of the population has, and there is something that you can do about it. And most of the time, it's not dangerous at all.
Hi everyone, Dr. Lee from Vital Discourse podcast. Love that you're here with us today. We're going to be talking about that ringing you hear in your ears. You know that loud pitch that sometimes people hear? We're going to talk about it. It's called tinnitus. People call it tinnitus. It's actually tinnitus with a US instead of an IS. But we're going to talk all about it today. Bothersome, non-bothersome, short-term, long-term. What is it? How are we going to treat it? What it means for you? We're going to get to all of it today on our episode of Vital Discourse.
So what is tinnitus? Tinnitus is an internal head noise, and it encompasses an umbrella term that encompasses all the head noise that we hear. Most people describe it as a ringing or the sound of crickets, that cicada sound, that buzzing. But sometimes it's pulsatile. It goes with or without your heartbeat. Sometimes it's pulsatile and can match your heartbeat. Sometimes it's pulsatile, but it's going in a sporadic, spasmodic fashion that doesn't go with your heart. And so it's important to distinguish it. Why does it cause so much distress? Well, think about it. I mean, you know what external sounds mean, and you know what if you're walking out between two cars and tires screech, you know that perhaps a car is coming. If your mom uses your full name, you know that you might be in trouble. But what happens when you have a noise inside your head? How are you supposed to react to that? The first time that you hear it, people attach a lot of anxiety to it. We're going to talk about some of the internal head noises that we hear, and Dr. Lee, some of them are pulsatile, not going with your heart. Some of those are spasms. Where do those spasms occur, though?
Yeah, so what we're talking about is, when we're talking about tinnitus, is we're usually talking about kind of that constant high-pitched or low-pitched that you're hearing in your ear. But there are all these other sounds, as Dr. Ben mentioned, that people will come in and say, oh, I've been told I have tinnitus. For example, when I told my primary care doctor about this. So the spasms that Dr. Ben was talking about is there are two little muscles in the middle ear, and they attach to one attaches to the bone, one of the bones of the middle ear, the other attaches to our eardrum. And what those muscles are designed to do is they're designed to make sure that when we hear a really loud noise, that it doesn't put too much pressure on our inner ear and potentially give us permanent hearing loss. So it's kind of a buffer or a barrier to really loud noise. Those muscles can go into spasm. And if those muscles go into spasm, then you can hear, and that's that kind of spasm that you're hearing sounds almost like a click in your ear. Another thing that you can hear is when your Eustachian tube, which is the tube that goes from the middle ear to the back of the nose that equalizes pressure in the ear, when that tube opens up and the air rushes through to equalize pressure in the ear, you can hear kind of like a popping sound. So we're not really talking about that type of stuff today. We're talking about that true kind of constant low or high-pitched sound that's very, very bothersome to people.
And that ringing in general is hearing loss. And so there's been a lot of ideas put forth, the Jastroboff paradigm, where in general we have an electrical system inside of our head, and there's a cost of doing business. The way our hearing works, the way it generates potential to send impulses to our brain is by having a semi-permeable membrane with varying ions on either side of it. And that gradient has a tone associated with it. And normally we don't hear it because the world's a very loud place. But as we start to lose hearing in particular frequencies inside our cochlea, we start to uncover or unmask the noise that's always been there. One of the studies that was done when I was in med school is they had 100 normal hearing young 20-year-old medical students, and they put them into an absolute soundproof room, and 100% of them heard loud ringing tinnitus. So it's always there, but we're never really in a position where we have absolute soundproof rooms. So as you start to lose hearing, you can lose it permanently or you can lose it temporarily by shifts in the Eustachian tube. You know, you got a cold and you're all stuffed up, or you're going up on a plane and your ears pop. Before they pop, your hearing goes down. You might even hear a little bit of tinnitus. And then when it pops, everything's restored. So one of the things that we want to talk about is, well, what can we do about that? The first thing you want to do is go see an ENT and or an audiologist and get a hearing test. Try to ascertain what's happening to you and how we might be able to help it. When you get an audiological test, you're testing multiple things, though, right, Dr. Lee? You're not just testing the hearing, you're testing the function of that Eustachian tube. What is that? What's that called?
That's called a tympanogram. So they put that little probe in your ear and you feel like your inner ear is getting all pressurized. That's a tympanogram. And what it determines is the maximum compliance of the eardrum. In other words, at what point, how much pressure can be applied that allows the eardrum to move one way or the other maximally. So that tells us whether or not there's normal pressure in the middle ear or negative pressure in the middle ear, rarely positive pressure in the middle ear. The other thing that we get from that type of probe is we can get something called acoustic reflexes. And what that is there's a reflex arc, kind of a nervous reflex arc that goes on in the inner ear. And if the reflexes are positive or they're negative, that gives us some indication of the function of the inner ear. But to go back real quickly, just really what we're talking about here, kind of to simplify it a little bit for people, is there's chronic machine noise, right? There's machine noise in our head that's always going. And we don't hear it because it's being masked by the natural noises that we always hear. When we can't hear the natural noises that we always hear as well, that machine noise comes to the surface, and that's what presents to us as tinnitus.
Absolutely, Dr. Lee. That's a great description of it. And so with that said, what does it mean for me? Well, I mean, tinnitus doesn't automatically mean that you have irreparable damage to your ear. As we just said, you come in, you'll get a test. We'll find out if your hearing is diminishing on an audiogram, that little funny sketch that you see the doctor looking at and puzzling over. The little spikes on the side is what Dr. Lee was talking about. That's the tympanogram telling him how well is that middle ear pressurized. Is the Eustachian tube doing its job, or are you having a temporary problem? If it's a temporary problem, your doc's going to work on trying to fix that temporary problem. What would that be? Don't be surprised if they do a scope on your nose, or if they get a CT scan to see if there's a fluid collection in one of the sinuses that might be causing that Eustachian tube to be sticky. The Eustachian tube, as you said before, can also cause clicks and pops and noises inside the head. Your ENT will distinguish between those too. But if it is hearing loss, they're going to talk to you about it. And one of the things you want to think about is that audiogram is based on populations, and it's a logarithmic scale. What does that mean? Well, that means that 0 to 10 is not the same as 10 to 20. And it's based on the entire population and where your hearing maps out. We draw an arbitrary line at 30 decibels, and below that line we say is abnormal hearing, and above it is normal. Well, if your line's totally above 30, they may say, well, you don't have hearing loss. That's not true. You don't know where you started. You could have started up at 0 and now you're down at 10 and it's normal, but you've got enough hearing loss to where you're hearing your internal head noise, your tinnitus, right? So what we typically try to do is talk to folks about their audiogram, talk to them about where it's coming from, where the noise is coming from, that ringing, and what we might do about it.
And not all hearing tests are created equal, right? So when you look at some hearing tests, they'll only go up to we measure hertz or frequencies, right? So we'll only go up to 8,000 hertz. Well, your tinnitus might be at 10,000 hertz. You can't really hear 10,000 hertz, but you can hear the ringing at 10,000 hertz, right? So
Yeah.
if the hearing test isn't expansive enough, you might miss a very high frequency hearing loss.
And so we've talked about what it is, and we've talked about how we can figure out what's contributing to it. What do we actually do? If you go back to the audiogram and you have tinnitus, and you want to try to ascertain, are you above 30? Are you normal hearing with tinnitus or abnormal hearing? If you're normal hearing, what you want to do is replace that absence of noise with a little bit of noise at the most quiet time, the time when it bothers you the most, which is in a quiet room when you're trying to go to sleep usually. And so they have tons of different noisemakers that you can get. I have loud ringing tinnitus in my left ear from about 50% hearing loss from my time in the military. And I have a little rainmaker, and I like white noise sometimes, or rain, or the sound of the beach. I can't play the sound of the beach on this Dream Machine because my wife doesn't like it because it's rhythmic. But everybody will find something that they can play, maybe even just a radio station, or there's a new microphone that you can put, a speaker that you can put under the pillow that your partner can't hear, but the moment you put your head on the pillow, you can hear it. So you want to mask that and replace the sound that has been lost. If it's below 30, your hearing's below 30 and it's abnormal, you want to replace ambient sound, most likely with an aid, some type of hearing aid. And it's really good now because the hearing aids that they have are fantastic. They're usually digital, and the price has been coming down for the last few years because of changes in the laws and how we present them.
So we've been talking about this horrible thing, tinnitus, this ringing in your ears. We've talked about how we have machine noise, this constant noise that we have in our ears that normally is masked by our normal hearing. But when our hearing is affected, it unmasks that machine noise. What we're going to talk about for the rest of the episode is we're going to go over, number one, the most important thing, do I need to worry about it? That's really the big thing, right? We're going to talk about how it's evaluated. We're going to talk about what we can do about it. And we'll end with something that a lot of people have found that they feel sometimes, which is something called a temporary threshold shift, when they're just kind of sitting doing nothing, and all of a sudden they get this really loud noise in their ear, and then it kind of calms down. We're going to tell you what that is. We're going to tell you whether or not you need to be worried about it. What we'll do now is we'll talk a little bit about, well, when you go to the doctor, what is the doctor going to ask you? What kind of questions is the doctor going to ask you? And what would a standard quote-unquote workup for tinnitus look like? So when you go to the doctor, they're going to ask you a few things. And when I say doctor, I mean an ear, nose, and throat doctor. And understand that there are general ear, nose, and throat doctors, and there are the ear, nose, and throat doctors that only specialize in the ears and nothing else. And sometimes your general doctor might see you and say, you know what, this is a complicated case. I'm going to send you to the otologist, which is the doctor that only deals with ears to treat it. But generally speaking, first of all, is it bothersome? Isn't it bothersome? Second, is it acute? In other words, does it just start? Or is it chronic? Has it been around for 6 months or more? Is it getting worse? Is it getting better? Is it low pitched? Is it high pitched? Is it roaring? Is it not roaring? And you can kind of figure out some of where it might be coming from based on these questions, right? And that'll kind of guide the workup. Dr. Ben, what after that would you do?
Typically, you talk with the person about their anxiety level over it. I mean, once they understand what it is, quite often they are relaxed about it. So behavioral therapy and cognitive feedback is very important in this. Trying to understand it on an intellectual level helps to diminish it, actually, especially if you realize that there is something you can do about it and replace it. So I typically talk about cognitive behavioral therapy. There are some really good apps out there. There are some really good support groups. There's there's American Tinnitus Association, ATA Online, that has a lot of good information as well. One of the things you don't want to do is reach for every snake oil that's out there. Realize that there are no pills for it per se, unless you want to try and take some anti-anxiety. If your anxiety is heightened by it or your PTSD is heightened by it, you may want to treat that. But there's really no pill for tinnitus. A long time ago, I don't know if you remember, George Gates and Larry Duckert were talking about a Mignette, a machine that gives pulses of air, and it would help with Meniere's disease, but also supposedly would decrease tinnitus, and it wound up not doing that. So there's a lot of devices for sale online that you're going to be bombarded with, especially if you're Googling tinnitus. The way it works today, the algorithm will start sending those things your way. There's really no cure for it except replacing the sound. And so in general, you want to allay your fears and decrease your anxiety, but when should you take it seriously? What are the times when internal head noise needs to be evaluated and might even be dangerous?
So I guess that's really the big question, because when people start hearing these noises, especially when it just kind of comes out of nowhere, it can be really, really scary. Now, the first thing is whether or not it's both ears or one ear. So you have tinnitus just coming from one ear, that can be a sign of trouble, right? So the first thing that we'll usually do, as Dr. Ben said before, is we'll do a hearing test, right? So if the hearing test shows that you have decreased hearing, especially in the high frequencies in one ear, but not in the other ear, then certain things can be going on. For example, it could be a benign tumor called an acoustic neuroma, okay? And if that's the case, then what we want to do is we want to do an MRI, magnetic resonance imaging scan, to see if there is an acoustic neuroma there. An acoustic neuroma, like I said, it's benign. Many times they're very slow growing and they just need to be watched. But if it really starts affecting your hearing and you start getting worsening tinnitus or even dizziness from it, then sometimes they need to be treated. They can be treated sometimes with surgery, sometimes with a kind of a targeted radiation therapy. So that's one of the big things that we see. The other is it pulsatile? In other words, is it not just that hissing, but you're hearing a shh, shh, shh? And especially if you feel your pulse on your hand and you can hear every time your pulse goes, you hear that swooshing in the ear, then it's likely vascular, right? So that means a blood vessel is involved. And if there's a blood vessel involved, then again, we're also going to try and look into some imaging studies to see what's going on with those blood vessels. So MRI.
And that might be normal. That might be because again, your jugular bulb and your carotid both surround, in the bony capsule of your head, surround your hearing apparatus. And so, you can hear the whooshing sound, especially if you lay on one side and cover the ear and block the outside ambient noise. You can hear internal noises like the whooshing of your blood. But there are some tumors that are vascular that occur in the middle ear, and we need to distinguish that. So that's what he's talking about.
And there can be purely medical type of situations. For example, high blood pressure. It could be the first sign of high blood pressure that all of a sudden you're hearing this whooshing, and you can hear that in both ears, right? Versus if it's just in one ear, and then we're talking about, for example, the tumors that Dr. Ben was just referring to, or a narrowing of blood vessel, right? So you could have a narrowing of your carotid artery, and how you are understanding that, or the symptom that you're getting from that is actually that whooshing in your ear. So we want to do vascular studies and that type of thing in those very specific situations, right? And then I think that's, the whole thing is we don't take everyone that has ringing in their ears and start submitting them to radiologic studies, right? We don't start rushing them into MRI machines or anything like that, because classically, tinnitus coming from both sides, right, is usually associated with a high-frequency hearing loss, and that's the main issue that we're dealing with. And then we're looking into things like masking, like Dr. Ben was talking about, something called cognitive behavioral therapy that Dr. Ben was talking about, which is a kind of a biofeedback type of mechanism, and then even sound therapy, listening to certain sounds can get you to kind of accommodate to the ringing. So, Dr. Ben, what should we not rush to do, right? In terms of, like you were saying before, snake oils or antidepressants or sedatives or those types of things?
Well, it's really hard to understand today what not to do because you're bombarded. The moment you type in tinnitus into your search engine, you're bombarded with all kinds of information, and most of it unwanted. You're bombarded with sales pitches as well for everything under the sun, from devices to medications. You're told that, a certain person has figured it out. I can tell you right now, nobody's really figured this out fully. We know that it comes from damage to the hair cells inside your ear. There is something you can do about it. You can mask that sound and you can understand where it's coming from. So far, we haven't been able to regenerate those hair cells that give us sound. We haven't really been able to regenerate them. But when we do, you'll know about it. So there is no cure for tinnitus, but there is masking of it. This isn't something that's dangerous to you. But if you go figure it out with your doctor will go through that algorithm Dr. Lee was talking about, and he will figure out if you're one of those very small percentage of people that needs further evaluation. So get it checked out, but don't worry about it. Come on in. We'll figure out what's going on. I know that tinnitus can be scary because it's fairly unpredictable, and you're the only one that can hear it. But if you come in and get evaluated, we'll be able to take you through the algorithm, see if there's a need for further evaluation for you, and then give you a real plan for how to get through this in a fairly easy manner. So I think that's the take-home message here, is that this is a quirky outcropping of our nervous systems. It's the way that it works. It's the way that we transmit sound. And as we get older or have hearing difficulties and the world gets quieter, this sound appears. And so masking that and living with it is something that a doctor can help you do.
Dan, I think buried in there is the why, right? Well, why is this happening to me? Well, yeah, you could be getting natural hearing loss as we get older, which congenitally or basically you got it from your parents kind of thing. Some people lose their hearing, especially in their high frequencies, earlier than others genetically. It could be loud noise exposure, right? So, for example, if you're
a concert you went to,
concert goer, that type of thing, and you
come out and your ears are ringing,
right? And you're standing next to that speaker, and so that right side keeps getting hit, or that type of thing.
Right.
That can certainly cause some permanent hearing damage. Viruses can attack the inner ear and cause permanent damage. So any of those things that can cause decrease in hearing can therefore lead to the tinnitus. So that's where the why comes in. And then the treatment part we spoke about, the treatments that are recommended, but the treatments that are generally speaking not recommended is treating it with sedatives. Sedative is not going to get rid of the tinnitus. It might make you handle it a little bit better. Certainly some people do get depressed from this, and treating the depression as its own entity is one thing, but generally speaking, we don't treat tinnitus with antidepressants, convulsants, or medications for seizures or that type of thing. The different supplements on the market, lipoflavonoids, ginkgo biloba, any of those types of things, none of them have really been shown to actually positively affect tinnitus. So take that as a very significant kind of vital discourse message of the day. Don't shy away from those Instagram posts that are telling you to buy their product and it's going to get rid of your tinnitus.
Yeah, I think the main point is get evaluated, understand what's happening, and realize that it's part of having a nervous system that's based in an electrical current.
Now, Dr. Ben, I want to ask you about something that really scares people. I'm sitting there doing some work. All of a sudden, I get this really high volume ringing in my ear. Starts super, super loud, and then it starts fading away. And I really can't hear out of that ear very well. and then over a couple of minutes time, all of a sudden my hearing comes back and it's gone. What is that?
Quite often it's a middle ear issue. And they can be temporary. They can actually, to get a little bit esoteric, you can sometimes have, remember, this is an active system. This is an actively tuned system. And you can actually have tinnitus that you can hear externally. You can lean in and hear it. There are types of tinnitus on an actively tuned system. And what does that mean? That means that the internal components of your ear are alive, essentially, and the cochlea has a membrane in it that is differentially sized to capture complex sounds and do a Fourier analysis and turn it into a whole bunch of very small sounds pieced together. Each width of the membrane, as it changes, has a hair cell associated that captures different frequencies. So my voice or a click might be a complex sound of multiple frequencies, but it's heard as a single sound. And it's a very complex system. When that system is tuning itself, it can sometimes create sounds. Otoacoustic emissions are a way of deciphering that. So the middle ear can sometimes, when it's not totally tuned, when you have a pressure that suddenly changes, can give you a ring that can sometimes even be heard externally.
Yeah, and you can also get what's called an inner ear temporary threshold shift. As Dr. Ben was saying, there's a membrane that occurs in the inner ear, and there's fluids with different concentrations of different substances, salts, on either side, in the fluid either side of this membrane. And sometimes you can get a little bit of a leak in the membrane. Sometimes you can get just a differential, because it's actually, believe it or not, it's an electric potential that occurs across this membrane.
We're going to talk about that in the vertigo section too, because those types of little fluid shifts and tears in membranes cause the gradient. Because you remember, the potential, an electrical potential, requires a semi-permeable membrane and a differential charge on either side of it. If you put tears in that, that's suddenly gone. And if it's in the ear, it causes a sudden hearing loss, which can be temporary or permanent, or a sudden dizziness if it's in the balance portion of this system. We're going to talk about that in another episode.
So the bottom line is, those temporary threshold shifts that you hear, like I said, all of a sudden you get this really loud noise and then it kind of goes away. Nothing to worry about, okay? Do they seem to occur more commonly when people are under stress? Yes, they do. Why is that? Not 100% sure, but it certainly does happen. So not anything to worry significantly about unless it's really happening a lot, then it needs to be checked.
Well, the temporary threshold shift is actually any time also that you can't hear suddenly, like when you're coming out of a concert. So that can happen, and as long as it goes back to normal, it was by definition a TTS, a temporary threshold shift. Obviously, if it's permanent after 3, and it's usually 72 hours. After 72 hours, the temporary threshold shift becomes a threshold shift, meaning that you just lost some hearing. So if you do that too much and you damage your hearing and keep going to concerts without hearing protection in, that tinnitus is going to get louder and louder and louder, and it's going to stay. So that's why docs always tell you, get the little foam rubby things, twist them up, put them in your ear, go to the concert. You're still going to hear that music fantastically. Matter of fact, it's so loud that it's actually coming through your bones as well. You're going to hear it great, but you're not going to walk out of there with that ringing and have that temporary threshold shift, possible hearing loss.
Now, Dr. Ben, say patient goes to their doctor and they say, wow, you know what? I've got ringing in my ear. And they do a hearing test. And the doctor looks at them and says, have you been exposed to loud noise? How does the doctor know to ask that question? What are we seeing on the hearing test that drives them to ask that specific question?
Oh, because high frequency?
Right. So it's at a specific frequency. And why did that usually at that specific frequency?
Yeah. So basically, that's why over age, we start to see the drop off in the high frequencies. The high frequency hearing loss is kind of, If it's happening in an older person, it's usually because of noise exposure throughout their life. It's also those hair cells are more susceptible in the higher frequencies to age-related loss and destruction. But yeah, I mean, we know that most of the noise that you're going to be hearing is complex, but the high-frequency hairs are actually more susceptible to damage from it. And so high-frequency hearing loss is pretty much synonymous with noise exposure.
Yeah, and we can actually explain this anatomically, right? So the cochlea looks kind of like a snail, right? Like the shell of a snail. It goes in a little rotation there, and there's fluid in there. So when sound comes in at a very loud volume, the bones in the middle ear, they get pushed really, really hard. They push against the membrane. That membrane pushes a wave in that fluid. The first turn of the cochlea are the highest frequencies, most specifically 4,000 hertz. So when we get a really loud noise, we get a slamming of that fluid wave right into that 4,000 hertz, and those hair cells at 4,000 hertz can permanently die off. And you can get this spike down in your hearing, and we see that in the hearing test. And that's how we know to say, hey, have you had some some loud noise exposure? That's why we ask the question.
Especially if the person's young. If the person's old, you pretty much know. What you don't know is, was it during concerts, or were they an engineer working around jet engines and didn't always wear their hearing protection?
Or especially if it's on one side, if they were in the military and they fired off of one shoulder.
Like me.
Like you. Yeah, exactly.
So look, we've covered a lot. We've talked about what tinnitus is. We've talked about how you should feel about it, how you should get it evaluated, what tests that we might run, when it's dangerous, and what we can do about it, what we can do to fix it. I think that everybody knows that internal head noises can be a little scary and unpredictable. But if you go and get evaluated and you see a professional, you'll be taken through a process that will allow your nervous system to heal and allow you to get past this anxiety-provoking problem of tinnitus.
And it's rarely something you really need to worry about.